It should be live in about 5 seconds here.
Okay, welcome everybody to the Fields Institute for Research in Mathematical Sciences. I'm assuming that we are live and that you are able to see us, and even though we can't see you. My name is Kumar Murty, and I'm the director of the Institute. The Fields Institute is physically located in downtown Toronto at 222 College Street. And I want to take this opportunity to acknowledge the land on which the University of Toronto and the Fields Institute operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. As you may be participating from elsewhere, may we suggest that you research the history of your land using the website nativeland.ca. Many of you, I think, are familiar with the Fields Institute, perhaps through your attendance at one of our programs. But for those who are new, the Fields Institute organizes a wide range of events related to research in the mathematical sciences. We span the entire spectrum of fundamental research, applied research, and even interaction with industry. The Fields Institute is a network of about 20 principal sponsoring and affiliated universities. We are funded by the federal government through the Natural Sciences and Engineering Research Council and the Canadian Institutes of Health Research. We're funded through the provincial government, through the Ministry of Colleges and Universities, the National Science Foundation of the United States, the Simons Foundation, and by individual generous donors, perhaps like yourselves. Our mandate is to advance research and training in the mathematical sciences. And as I said, we interpret that in the broadest possible sense. In particular, last January, we were watching with alarm the progressive spread of COVID-19 around the world, and decided that we, as mathematical scientists, would mobilize a national task force to consider the modeling problems involved in the pandemic. We met in Toronto in mid-February, and that was a time when we could still travel and meet together. And we formed the research plan of the group. It's interesting during that meeting that one person said, we were talking about the lockdown in Wuhan, but said it could never happen in Toronto. And here we are. Indeed, it did happen in Toronto. You can see the work of this task force, this research group, on the Fields Institute website. And in particular, we have a weekly seminar, Tuesdays at 1 to 2 p.m. Toronto time, which is open to the public. That's where we discuss the various mathematical developments in the modeling. So those of you who have an interest in the technical details, I draw your attention to that seminar. You might want to check out that seminar and join it when you're able to do so. We will soon be publishing a volume of proceedings from the papers presented so far. Many of the members of that task force are also on various provincial and federal advisory committees to communicate the science to policymakers. The flip side of communicating science to policymakers is that one also needs to speak with the public to hear their comments and questions and to share whatever knowledge we have with them. And that is why programs like this town hall are so important. The fact that we have a registration of more than 600 people shows that there's a real appetite in the public for this kind of dialogue, and the Fields Institute is delighted to be able to facilitate that. One aspect that has become very clear during the past year is that the science involved in the pandemic is actually very interdisciplinary. And for the work to have practical relevance and importance, math needs to be able to talk to public health and medicine. And we need to also be able to talk to people who are involved in the formulation of policy. Our panelists today exemplify that interdisciplinary ability in abundance. Extraordinary researchers, extraordinary communicators, and I would say also extraordinary human beings, as you will see in the discussions that we have. Let me introduce our panelists to you. First, Peter Jüni is the scientific director of the Ontario COVID-19 Science Table. In normal times, we call normal times, is the director of applied health research at the Li Ka-shing Knowledge Institute of St. Michael's Hospital. Peter is internationally renowned for his clinical research on the management of cardiovascular and musculoskeletal disorders. Peter has played leading roles in major cardiovascular trials and served on task forces of the European Society of Cardiology. Peter holds a Canada Research Chair in Clinical Epidemiology of Chronic Diseases and is professor at the Department of Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto. Our second panelist is Sharmistha Mishra. She's a member of the Ontario COVID-19 Modeling Consensus Table and assistant professor at the Institute of Health Policy Management and Evaluation at the University of Toronto. And she's a research scientist at St. Michael's Hospital. Sharmistha's research focuses on modeling disease transmission and adapting public health strategies to meet the needs of population at differential risks. She has worked in Sierra Leone during an Ebola outbreak, and during the current pandemic is modeling the spread of SARS-CoV-2 with a focus on examining and evaluating population and place-specific interventions. Sharmistha holds a Canada Research Chair in Mathematical Modeling and Program Science. Welcome, Sharmistha. Welcome to both of you. I want first to begin by thanking both of you for making the time to join us this evening and to share your knowledge and insights. I know how busy both of you are. I know how many official capacities you serve, and we really appreciate being able to listen to you. Just to be clear to the audience, I want to say that our panelists are speaking on their own behalf, not as representatives of any entity, but they're expressing their own understanding and views. Now, we asked the public to submit questions that they were interested in hearing about, and we got quite a few. We've gone through them and sorted them into a few topics, and that's the way we will organize the discussion today. But first, I want to thank everyone who took the trouble to write in with a question, and I apologize in advance if your question is not read out. Assuming there is continued interest, we can organize further programs of this kind to take up those questions that we couldn't get to tonight. Okay, so with those words of introduction, I wonder, Peter and Sharmistha, shall we just jump into the discussion? Yes, okay. So the first question comes from Tony Choi, and he's asking about the lockdown. How was it determined when to lock down, or how the stay-at-home orders? And how do we determine how long such lockdowns or such interventions should last? What goes into those decisions? And more generally, what goes into the decisions to formulate decisions about public health measures, like the requirements for masking and physical distancing, etc.? Andrew, whoever would like to answer that.
Sharmistha, shall I have a first stab at this one, and then we'll see how it goes. So, one of the real challenges we have, you heard that from Kumar. Or you can't know, but typically in my life before the pandemic, I can't remember how this life actually really was to a certain extent. I was a trialist. I did clinical trials, and I was very much into trying to inform decisions by good, robust clinical trial evidence that would give us the best possible answer if we're treating patients or if we introduce a public health intervention, etc. And we need to be aware of that we're in the middle of a pandemic, and none of what I actually learned and was socialized with during 25 years is actually holding to the same extent anymore. We very much need to use a toolbox of interventions that have been around for more than 100 years, have worked in various pandemics in the 1920s, even before that, and then repetitively. And there was never really, the firm amount of evidence that we typically have. And we need to live with this toolbox. And we know it works tremendously well in a situation that we are right now, where we have a pandemic, where nobody actually is immune against the virus that we're talking about, SARS-CoV-2, meaning if we have the virus in the province and nobody steps on the brake and has a certain amount of restrictions, what we know is that the pandemic actually self-accelerates, gets faster and faster and faster, and we will end up in a very dire situation, as we've seen it in New York at the very beginning, and as we see it right now in Portugal. In this situation, what we need to do is we need to try to understand a common understanding about when it's time to go to a next level of restrictions so that we can avoid that the pandemic gets out of control. And this is typically based on the number of cases we see daily or weekly. It's based on the curve, the epidemic curve, the slope, how steep this curve is, and how much we see the pandemic currently is under control, and how much we actually are concerned about the regular measures just being the regular systems actually being overwhelmed. This includes first, our testing and tracing capacity. If we are unable to test and trace and to pinpoint who is actually ill right now, with whom this person would have had contact, etc., that's a first level where we say, when this system starts to be overwhelmed, not good anymore. Then we always keep, and that's then Sharmistha's domain, and she would need to comment on that, we keep trying from the case counts that we have to develop an understanding and project into the future. How will it look with our healthcare system, with the number of hospital beds occupied, with the number of ICU beds occupied, knowing that, Ontario and Canada in general has a relatively thinly spread healthcare system already. And obviously we also look into then, the projected number of fatalities, of deaths that are happening. And there will then be in a healthcare system that works well, and not all work as well actually as what we have here in Ontario, there will be a framework with which we actually determine, okay, now we reached a certain level, we need to react.
And in following what Peter was describing, we have to think about, measures with respect to what the impact would be on transmission. And that means thinking about what are we trying to actually achieve with these measures, with any kind of public health measures or any kind of intervention. And what we're really trying there is to reduce the number of contacts that folks may have with each other and who has contacts with whom. And a recognition that that's not spread evenly across a population or contexts or spaces. So it's a very different context in a highly dense population that may come into contact with each other a lot more. For example, household density, and a completely different city or neighborhood that has way less household density and number of people who may come into contact with each other at baseline. So those factors also come into play when we think about the measures and how much of those measures can actually influence contact rates and where that might saturate out. And so there we fall into elements of for whom do these measures work, and in whom are we able to prevent transmission, prevent hospitalizations and death. And if we know that that intervention or measure can't reach everybody equitably, what are the other things that need to be put into place to achieve that? And so that's also part of the framing around these public health measures and thinking about the timing of them as well, and being able to come out of restrictions by enabling certain structures to be just less at risk, for example.
And the point really is viruses don't have legs or wings, no? So they need people to go, from person to person and people's behavior. And the point really is everything we're doing basically is we try to decrease the amount of contact all of us have with other people. That's basically the common denominator of everything we're doing. That's what we need to avoid. And I'm not sure, Kumar, whether that's okay. I can quickly, when we talk about projections, perhaps show you a slide quickly that helped us to understand that we were really in a dire situation on January the 10th. I quickly tried to share my screen and just go to a slide here. Let's see whether that works. It may actually. Yeah, here we are. Can you see my slide?
Yes, we can see it.
So look at that. What you see here is that's coming from my personal dashboard, actually, but this is the same when you go to the official dashboards. Do you remember after, the situation we were in after the holiday season, where unfortunately roughly 50% of people in Ontario, and that's internationally the same, didn't adhere to the recommendations and met anyway? What we then saw is that numbers creeped up, no? And what we then see that, the past is typically a relatively good predictor of the future coming. If we used the growth, the epidemic growth that we had here in terms of the number of cases on this trajectory and projected it into the future, we knew that if this, what we had experienced first during December and then over the holiday seasons would continue, then very easily by 15th of February, we would be roughly at 11,000 cases per day. Right. And that's then the situation, where it becomes abundantly clear if you are in this really challenging situation, you need to react. And this was not only that we had just to hope that the holiday season now is over and people adhere more, we had to step on the brake just more. And that's, one of these situations. It is these sorts of projections that make use of the behavior of a virus that doesn't have anything, opposing it. There is no immunity in the population, where this will go. You see the self-accelerating elements. It goes very quickly within a month. It can, within a month actually, I don't know, 3,000 cases or so can become 11,000 cases despite some measures in place. And that's the challenge we're talking about here.
And Peter, just to be clear, that the projection that allows us to show that's the shape of the graph comes from some mathematical model that says that the trajectory conforms to a certain pattern. Is that right?
Yes, this is correct. Yes, indeed. And that's one of the challenges that we're talking about, exponential growth. And actually, I should let you talk, Sharmistha, or you, Kumar. But the point here is exponential growth really means that every week, every 2 weeks, or every 3 weeks, depending on how quickly this goes, the infections double. It doubles and then it doubles again. And at the beginning, this is very subtle, 1 becomes 2, 2 become 4, 4 become 8, etc. But, if 2,000 become 4,000 within a week or 10 days, then it starts to be a challenge, daily infections.
Right. Good. Very good. Thank you. Sharmistha, did you want to add anything to that?
Just that importantly, those trajectories do look different in different communities and different geosocial and political contexts. And with that are different buffers that our healthcare system has to be able to absorb that and to be able to care for patients. And so all of those factors come into play when thinking about, trying to put the brakes on something. And I'll just to add to Peter's element on contact rates, many of those are still structurally mediated. So in workplaces and in certain networks, for example, in congregate living settings, they're not necessarily fixed, but they have sort of a boundary to which we can kind of not be able to make them any less dense than they already are currently. So other things need to be at play if one part of an equation, which is contact rates, actually can't be absorbed any further.
Right. So I think that, thank you for pointing out that in fact, as Peter showed one graph, but actually you're tracking many graphs and many aspects of the ways in which this is stratified and the way we have to react to that. So just maybe sort of segue to that, there's a question from Christoph Hebermel from Toronto. He asks, based on the number of cases we have seen in Canada and other countries, do harder measures over a short period work better than softer restrictions over a long period?
You first, me first, Sharmistha. To be honest with you, I changed my take on this one quite a bit because of us all being humans, and it's part of the human nature to try to escape when things get uncomfortable. And all of these restrictions that we're talking about are challenging sometimes, and sometimes we just try to escape, and in many situations we don't have any choice because we need to work as essential workers, contribute so that all of us actually just get food on the table, into the shelves in the supermarkets, etc. And initially we tried, when you remember that in November, December, to have a more differentiated picture, also just acknowledging that different parts of the province are burdened differently. But what we then saw is that this didn't work out as well as we could. And meanwhile, I came to believe, and we also see that probably the best bet in these situations is to react early, relatively harsh, and relatively systematically, in a geographical area, to get this thing under control, get the numbers down, and then start to open up again. We just all, we also get tired. We're not in the first wave anymore. At the beginning, we were all very adherent. We were concerned. We were scared, etc., etc. It was new. But we get tired over time. And now, in a way, we need to step a bit more onto the brake to achieve the same as at the beginning. And we tried hard. October, November, December, we weren't that successful. We were still, clearly successful. If we wouldn't have had these sorts of restrictions, numbers would have exploded already in December. But it was simply not good enough. And therefore, this lockdown that we're in right now.
And I'm going to share a figure that I think describes what Peter was talking about. If we take a look, for example, at the epidemic curve shown here for the city of Toronto. And what we're showing is an epidemic curve on the red for neighborhoods that have been stratified by the proportion of the population that works in essential services. In red here, in green is sort of the next strata, so about 40% of the population work in essential services. In blue, only about 20% of the population work in essential services. In red, it's about 60%. These neighborhoods where there's the highest proportion of folks working in essential services also correlates or overlaps with higher proportion of households that are multi-generational. And so what we were describing is, as Peter talked about, putting on the brakes and trying to reduce contact rates, we achieved that. And we have reduced the epidemic in the first lockdown and then in the second set of restrictions. But what we see is this fanning out in terms of the inequities in where epidemic has concentrated. And this really reflects what's left over after we sort of try to reduce contact rates through public health measures based on restrictions and closures of some businesses. And so really, this is reflecting the proportion of the population that is shouldering the disproportionate burden of cases in the ongoing pandemic. And this is up to about early January when, as Peter was describing, the additional brakes were put on. And as a result of those additional disproportionate cases, what we're seeing is that, and the colors are flipped around here, but this blue line represents those same neighborhoods with respect to now looking at the cumulative rates of death per population or per capita. And essentially, the neighborhoods with the highest proportion essential workers have almost a 6-fold higher per capita rates of death. So they're also shouldering the disproportionate burden of hospitalizations and deaths as well. And so that's really reflecting how much we can do with current measures, and how we can reduce that with adding on additional measures to put the brakes on, but the gaps that are left over as well.
Yeah, I mean, it's relatively easy for people like me who work from home not to get infected, but a lot of people out there who get the work done on our behalf don't have this privileged situation, and that's what we're seeing on these graphs. And these people need our support, our help, and need now also, you know, when we talk about hopefully in a few weeks or months the vaccine rollout, also, you know, a priority.
And this is important. I think this element of and a recognition amongst many of us who have the privilege and the opportunity to be at the tables, to recognize that many of us are less affected by additional restrictions than many other communities. And those who have been particularly essential, working in essential services and the intersection with multi-generational homes. And that's an important element, I think, to the recognition of the communication also of public health measures as well.
So I wonder if I could pursue that a little bit more. So we have general kind of interventions that help to slow the growth to some extent. And then we find that there's a second level, more nuanced bifurcation or splitting of the growth. And both of you have mentioned that we will now, these people are shouldering the heavier burden now of the disease, and that they need our support and help. What do you think we might be able to do? This is not a scientific question, but maybe it's a question based on your knowledge and experience. How can those sections of the population be helped? How, and what kind of assistance can be given to slow the spread amongst them?
Peter, do you want to take that first? I'm going to try to pull up our prevention gap figure as well at the same time.
Okay. So you see, we have, there's a paradox, which is that everything which is actually needed in communities that are burdened most is least available in these communities. Really everything. It starts with, you know, that thanks to a lot of people who try to spearhead initiatives, for instance, in Toronto, we know that relatively well. If you are in a neighborhood that has more cases, you need to get access to testing. But there are neighborhoods out there with a lot of people not having cars. The nearest testing center actually just, you know, requires you to have a car just to get there, for example. So what we actually talk about here is very much that we start to tailor our support to the necessities in the community, working with the community, have really, you know, just this bottom-up approach from the community to people in the community. While on the other side, the province can help to, you know, give the necessary legal framework, the necessary financial support, etc. Like, you know, a stop of evictions, for instance, is really important. You know, we still struggle in this province and in a lot of places in North America with paid sick leave. That's the part where the province can contribute, but a lot is also that we just feed in support so that grassroots, that the support actually can grow in the communities, and is really also just tailored to what is necessary locally. A one size fits all approach doesn't work there. Mm-hmm. Testing, a support with isolation, simple stuff like, you know, support with filling in the forms that me as an immigrant still don't get it, you know, if I have to fill them out, support with isolating if it's needed, especially if you're in a precarious living situation. You know, if you live with 6 other people in a 2-bedroom flat, how should you possibly isolate? All of these, you know, common sense aspects that don't work, where those people need most support.
And I think it's important to recognize that there are multiple layers, as described, of interventions and strategies. And many public health measures at a broad scale really are one size fits all. The attempt of restrictions and closures, for the large part, is meant to try to reduce contact rates across the board. And then the question is, what proportion of the population, and importantly, what proportion of the networks or contacts does that not reach? And therefore, we end up with more that's needed that is tailored to the persistent mechanisms that lead to transmission. And that works out mathematically. So I'm going to show a figure from a simple transmission model that takes a population and says, hey, we're not all the same, that we've got different differential risks at baseline of transmission. So for example, through household density or essential workplaces. I'm going to show this figure if we think about even as simple as two neighborhoods that are interconnected, but in one neighborhood, the network risks are higher. So we're thinking again about neighborhoods with higher household density, multi-generational homes intersecting with essential work, for example, and neighborhoods that experience lower risk at baseline, so larger proportion of the population who may be able to work at home and less individuals per household. And then, and right over here is the combination of those neighborhoods together if we're looking at it at the city level, for example. And in the gray would be our epidemic curve as our base case. And if we apply a strategy such as that pink or dark pink dash line, and what we do is we assume that, hey, it is going to reach everybody. What we would really get is that gray dash line. We design and assume that our public health measure will reach everyone equally. And in fact, perhaps that would be, for example, public health measures or restrictions that would reduce contact rates by 25% within high-risk neighborhoods as well as lower-risk neighborhoods. But what if in reality, and this is actually what we observe, the strategy doesn't work as well for neighborhoods that are experiencing higher risks? We end up with this gap that we call the prevention gap. Essentially, what we think is going to happen, that gray dash line, doesn't happen because we're left with actually increasing inequities and concentrating the epidemic further in neighborhoods or networks really experiencing higher risks, shown here. And that can be true of networks when we think about it at the community or population level. That's also true when we think about it at congregate settings, for example. And that's a really concrete example of recognizing that in congregate settings, we have to do a lot more than try to just reduce contact rates within congregate settings, knowing, for example, in long-term care homes that we may be fixed with respect to beds per, number of beds per room, for example, until structural changes can be put into place. So it's taking that same analogy and thinking about community congregate settings, and now really starting to think, our households also have some of those differences. Our workplaces have some of those differences. And those epidemic curves that I showed before with respect to the epidemic curve by stratifying neighborhoods by essential services, they're as different as looking at the Atlantic provinces versus Ontario, or looking at some countries versus looking at Canada. So within our own local context here, we're seeing that level of epidemic differences.
When I was bringing our oldest daughter to Switzerland back to boarding school end of August, the penny dropped for me. I arrived in Switzerland, and this was basically like, I have been to Canada before, just all the time. This was basically like nothing had happened. There was no pandemic. Nobody was wearing masks. I was the only weirdo who was wearing masks, in the supermarket or in when I was getting something for my computer, etc., etc. And it was like nothing had happened. And this continued like that for a relatively long time. And the pandemic just stayed under control. It just stayed under control, miraculously. They stayed in a phase where there were a few cases, it lingered a bit, they did a bit of contact tracing, and they came back, and I couldn't believe it. I talked to one of my colleagues who is an infectious disease specialist and told him, Christoph, I can't believe what I see. And then it started to dawn on me. That's when I started, when Sharmistha and I started to have contact, then when I just realized, wait a moment, what is happening here is that a highly privileged country, with a lot of social security, with a lot less structural problems, not many precarious living situations, etc., what they basically can afford to do and nothing happens. If we had done that in this province, we would have been in big trouble already end of August, beginning of September. And Switzerland could afford it until beginning of October, and they just did everything wrong they possibly could, to be honest, before it actually started to go wrong. Why? Because their structural baseline is a completely different one than we have. We have 20% of the population that is really, really challenged, income-wisely, professionally, with the working situations, socially, etc. And this makes a real difference. And what this actually means, me again sharing quickly my screen, is that when you look at the province, what you see is that the burden during the entire pandemic, first wave, second wave, the burden of the pandemic was always just in those spots that are red, orange, and then perhaps yellow, but not in the blue ones. When you go north, of course, this is because we were lucky that this wasn't imported into the north. But when you look at the south, these areas that you see here, that's always special areas where we have, more people in essential workplaces with worse living situations, etc. And it's always those who get hit hardest. And that's the challenge we're talking about. And what we need to, what we would need to achieve is a situation where we stabilize exactly these living conditions, social conditions much more, so that we can protect these people much more who actually are getting the work done on our behalf.
Very good. Sorry, go ahead, Sharmistha.
Oh, no, I was just going to say, and along those same lines, when thinking about an epidemic or an outbreak taking off, it's not just the virus alone. It's really thinking about the contact network and the underlying structural that's at play as well, which also means that if it takes less to actually dampen the epidemic when there's a network that's not as tightly connected or not as dense, but also has additional things like access to paid sick leave and so forth to be able to quickly quarantine and isolate. So we reduce the duration of what we call duration of infectiousness, which is an element of transmission as well. The opposite of that is when we've already got a dense network with additional barriers to things like early quarantine and isolation, and a growth of that epidemic, that even small things like one gathering can look like it's creating a lot more transmission than if we take another context where there's 5, 6, 7, 10 gatherings that don't lead to onward transmission. And so one of the challenges that has come out of a lot of the heterogeneity that we observe in our epidemics is that sometimes what we see is just what's at the tip of the iceberg. And so we end up blaming a gathering when there's actually the root underneath that iceberg that are the structural factors that are at play that'll let one small gathering lead to many transmissions versus in another context where there's not very much underneath the iceberg. And so multiple gatherings don't lead to that. And so we end up with this, what's visible to us versus what's actually at the root, which is the density of our networks and the barriers to quickly isolating and quarantining effectively because of structural barriers that persist, particularly in the context of precarious work.
Do you know, Sharmistha or Peter, in previous pandemics, had this kind of nuance been identified? That we're looking at something beyond the raw contact numbers, exactly the network, the graph, if you like, of it. Is there any work from previous pandemics that exposed or analyzed that?
So I'll speak to epidemics of HIV and sexually transmitted infections, where actually a lot of the epidemic theory work actually came out of, was thinking not just about sort of the basic, the equation for the reproductive rate, but rather starting to look at, well, what if there was a difference in the contact matrix? How would that, or dispersion, over dispersion, how would that affect sort of not just secondary transmissions, but onward transmission? How does that influence the growth and the of an epidemic? And for HIV and STIs, or sexually transmitted infections, the chance of transmission is actually really low. So we actually need these, what we call these very assortative networks, or, like with like when it comes to mixing, in order for an epidemic or an outbreak to take off and to emerge and then to sustain or persist. So it's really a fundamental part of most HIV and STI transmission modeling and epidemic and public health response as well. But having said that, it took time to get there. A colleague and I were reflecting on how there were decades of work on HIV epidemic, where it was thought of as general population and key populations as separate contexts. And the more that we started thinking about key affected populations, those most at risk of acquisition and onward transmission, then interventions started becoming more tailored versus sort of universal strategies that in many ways actually disproportionately didn't reach key populations. Outside of that context, from an applied public health perspective, yes to small outbreak investigations and outbreak response. So thinking about that from the context of Ebola, for example. But in general, what was interesting in this pandemic was sort of partly because of the speed at which things, I imagine, had to take place with respect to understanding transmission early on. It wasn't a large feature for several months. But it has been from prior, especially theory, absolutely, and epidemic theory, and from other infectious diseases. Peter, I don't know if you,
Yeah, well, we're about to publish a paper in Annals of Internal Medicine in the forthcoming week that looked at the 1918 influenza pandemic in the Swiss canton of Bern. And while we obviously had limited data, what was clear, that there was a considerable variation again in the pandemic burden in Bern, in the canton. And guess what? There were two aspects which were important. It was, proximity to the border. This was during World War I. And then the areas where there was a lot of industrial activity. This was watchmaking actually at the time. These were the areas first that were burdened most. And after that, it was actually, the burden was most in the areas where we had a lot of army that was being used to get the general strike under control, that were themselves then in congregate settings. So first, in the first wave, we had just all the watchmakers, industrial settings, all under one roof. Viruses love it indoors. And after that, it was probably, we can't prove it, but it was probably the soldiers actually that triggered then, the pandemic to really flourish in the small town of Thun, where the burden was disproportionately high, because we all of a sudden had thousands of soldiers there in the casernes.
It's interesting that as we deal with this pandemic, it seems to me we're learning. The field of epidemiology is growing too. I mean, if you can publish a paper now giving new insights on the 1918 pandemic, it means that we, in some time, correct me if I'm wrong, if I'm overstating this, but we're applying things that we've uncovered now and realize that actually these issues were there before that we weren't aware of. Would that be an accurate statement?
Yeah, including all the interventions. I tell you, it's humbling. It's exactly the same interventions that we're talking about. And they did it, as for the case in Switzerland, they probably did it better 1918 than 2020.
I was going to say exactly that same word, Peter, humbling. How much the pandemic, our response, and has revealed how much we don't know. How much we need to be skeptical and question what we thought we knew and the assumptions that we've been working with for a while. And that interdisciplinary nature, Kumar, that you mentioned right at the beginning, how much we're learning from each other around sort of how we think things happen causally, how we think things affect each other from a nonlinear sort of propagation perspective, and how much the past could actually have told us and is telling us so much about what we're seeing now. So Peter, I think that paper is fundamental to sort of reflecting back and saying, where we saw our concentration of respiratory virus illness decades ago, and also where we saw our flu outbreaks and our mortality several years ago, and over the last few years, that's where we've seen the outcomes of COVID now as well within our own cities.
Interesting. Let me take us to a slightly different topic now, but it's connected. We just spoke about community settings. Right now, there is talk about schools that will be opening shortly, maybe in a week or two. And I'm sure that's a relief to many parents from one point of view. But perhaps both of you could speak about what we know about this, about how how we decide it is safe to open schools, and what the unknowns are here, and how we are actually coming to this conclusion, and how we could safely navigate it.
So yeah, to confirm that, we all know that who have small children at home. I have a 6 and 8-year-old just over there who were noisy just before, which sort of challenged me a bit because of the town hall. And we all are aware of that. It's a burden to families, especially again families of essential workers, living situations, where people are really just in much closer spaces than I am here. For sure, that's a real issue there, and we're all social animals, and the social connection is terribly important for kids. So, as I think here in Ontario, as a society, I understand this was a value judgment we all made. We want to prioritize schools. Now, what is really important is that we let go of the narrative. Children are not a problem, and and I still hear that, from some colleagues also, and that we just make this extrapolation from, luckily they don't get severely ill, in general, and luckily they don't, end up on ICU, etc. This is wonderful. But this doesn't mean that they do not contribute to the pandemic. And this is just the first step here is to get onto the same page, which is even more the case probably now with the new variants that are emerging. Children, as in any other respiratory disease, probably play a role, period. And we're relatively sure, meanwhile, that for the older children, that's certainly the case. But the more this evolves, also with the mutations coming, etc., it could well be that also with the new data we're having, that also younger children play a role. So the first thing is we need to take it extremely seriously, period. And then, don't get emotional, just follow good strategies. That's then really the next step. And the beauty of a school as compared with a bar is basically we know who is in a classroom, and we can just, just make sure that it's always the same students in the same classroom, and the classroom or the students in the classroom do not interact with each other. That's the first thing. That's what we call cohorting. That's one of the first lines of defense. There is the physical distance, of course, it stays important. That's not always possible in the classroom. The masks, we do a much better job in Ontario with masks. And we actually learned that the kids, also the small ones, actually can wear them. If we don't make such a big fuss out of it and just teach them a bit, they're actually cool. My kids here, they're completely okay. They do a better job than I guess, with a mask. No, there's this part as well. And of course, the general hygiene and so on. But the part of just keeping the class together then also means that if there is an infection just introduced into the school, it stays in the class and doesn't jump from class to class. Remember the Titanic, when it hit the iceberg. The reason the Titanic sank is because the compartments in the bottom of the ship were connected to each other. That's why the water spilled from compartment to compartment. That's the metaphor for schools. If we keep the compartment safe and not connected to other compartments, we can even keep schools relatively safe. And we need to find new ways, of course, now to move forward, also because of the variant and also because of right now, perhaps some schools opening when the community transmission is relatively high, meaning that the risk to introduce, an infection into the school is higher now than, let's say, last September. And we need to be aware of that. So treading carefully and also prioritizing as a society now. If we want to open schools, we need to pay the price and be calm with the rest. We can't open everything at the same time. This is almost guaranteed that this will backfire.
And I think reflecting also on all of the unknowns. So one of the key elements of this pandemic has been, and of every pandemic or every outbreak and of infectious disease epidemiology in general, is, we see what we see, and there's some things that we don't see. And so we need to think about why we're testing, whom we're testing, when we're testing. And so what do we observe? And what we don't observe, we need to think about the viral dynamics. When is somebody more likely to pass on infection before becoming symptomatic? How does the range of symptoms, how's that different for kids versus adults? And who's in contact with whom? Elements of the virus's biology around susceptibility versus sort of viral load and passing it on. And all of these come into play in such a way that I think, reflecting on the big picture element of what Peter just said, which is how do we make places safer? And that's schools, but that's also workplaces. That's our farms, that's our warehouses, manufacturing. We've managed to do it in many acute care facilities and hospitals. Lots of work still to go for long-term care facilities and even some acute care hospitals and facilities as well. But essentially, where we know people, for a variety of reasons, need to congregate and need to come into contact with each other, how is that done in a way in which it mitigates risk? And a big element of that is when we think about it from just a workplace lens, enabling and supporting and facilitating the ability to isolate and rapidly quarantine and reduce our contacts when we can pass on infection needs to be in place. And in many schools, that is more possible than in many workplaces with precarious work, where educators may have the opportunity and the financial and, importantly, the paid sick leave support to be able to do that, versus in other workplaces where we don't. So it's really about those same principles, I feel, apply across contexts in order to make them safer spaces. And then the last element of that is when really thinking again about that intersection. If we're thinking about transmission within schools, then leading back through sort of secondary transmission to the community, then how would that be mediated? And is that through multi-generational homes and essential work that then sort of brings like introduction in and then sort of, I guess not introduction out, but sort of perpetuate or feedback loop out? Or is it more introduction in? And so really thinking about, once again, as Peter described, reducing community risk through where we're seeing it, which is, at our essential workplaces and multi-generational homes.
And you see, the playbook is always the same everywhere. It's the same few tools in the toolbox that we need to use, and we need to live what we have with what we have, and just use the resources that are available to the best optimal, best possible way. This means, okay, yes, of course, we need to try to ventilate classrooms as well as we can, but we can't do miracles. We can't just build new schools now all of a sudden. So just everything to the best of our ability, use good common sense, and always just think about the same thing there. It's simple. This virus likes to be inside in not well ventilated spaces, and it likes people to be close to each other. Okay, so let's talk about that, and just in every single situation, avoid exactly that as good as we can. And that's the same playbook in a warehouse, in a school, everywhere else.
Mechanistically, and a colleague of mine, I'm going to give him props, Stefan Burrell mentioned this, the universal truth that comes out of this is sort of contact rates per square foot or square meter, going to the metric system. And that applies across settings with all these other caveats and amplifiers at play.
Very good. Thank you. That throws a lot of light on this. And especially it highlights, one thing I like in the way both of you present your ideas is there's a lot that's unknown. We are learning as we do this. and we have to do the best we can under the circumstances that we find ourselves. Still in the theme of sort of getting on with life, so to speak, we have a question from Miriam Sherman from Toronto, and she asks, okay, so say I can't wait until the vaccine is available. When is the safest time to go and get dental work or other essential healthcare issues taken care of? What would you say to that?
You, me? I don't know. To be honest, we need to be aware of right now, we're in the most challenging part of the pandemic. We might talk about that a bit later, but things will get easier. So again, I said it before, this virus likes to be inside. So the moment we're able to go outside because the weather will be nicer, things will get easier, not only because we're less depressed and have more sunshine, but because we're able actually to meet outside and to have activities outside. And we know then that, given the same amount of restrictions, things get much easier and the pandemic gets under control more. This will most likely be the case now as well. This is not about temperature per se, not about humidity per se. It's just merely the fact inside versus outside. If we're outside, it's much safer, whatever it is. So we will probably have a honeymoon phase before the vaccine kicks in, just because of the nicer weather here in Ontario. So if you really want to go and play it completely safe, then go when the community transmission is lowest, and this will be probably when we look into that end of May, hopefully June, July, etc. But we also need to be aware of that the measures in place now, that the dentists have, others have, are actually really good. And, we learned a lot and people are doing a really good job there. So if you have to go, because you need it, you just go. And I don't think that this is such a particular issue. I'm not sure whether you agree, Sharmistha.
Yes, absolutely. And the efforts that have been put into making workplaces, especially for healthcare and dental care and other care safer, has been remarkable. So if it's needed, absolutely. If there are things that can be held off for a little bit, that's also okay too. And a recognition that we all have different levels of sort of our personal and family, risk. But I think the measures have been put into place to make healthcare, and that includes dental and mental health and other care, very safe.
Good, thank you. I'm going to go back to something Peter alluded to about the way that the summer will be. And I want to ask a question from Sarah Nayani from Toronto. She says, when will we get back to normal? And what will normal look like?
You?
You start. I'm going to turn on the light.
So first of all, just to make that very clear, if we talk about this summer, remember the last summer, it will probably be the same period, okay? Which is not too bad. Considering everything where we are right now, it's not too bad. Don't expect miracles. If you think about how things were 1.5 years ago, let it go. It will not be the same anymore. So the new normal will not be the same. We will have certain acid tests that will be coming. I believe that, the summer will bring relief, as we said, and we just meet outside and we go to, I don't know where, Toronto Island, and on the ferry, we just have the distance and we wear a mask, etc. This will all stay as it is. And then the vaccine will slowly kick in. I hope we will be able to vaccinate really smartly, and bring the vaccines to those people first who need it most, as we did it now for long-term care homes. And this will be sort of okay. And then the acid test will be coming. Sharmistha and I talked about that actually today. Once we start to move inside again, end of September, beginning of October, we will see how this all goes, and we need to tread very carefully. By then, we will know a lot more about, the vaccine efficacy, also against transmission, susceptibility, etc. This will all help us, but we just should not believe all of a sudden it's back to how it was before the pandemic. This won't happen that quickly, really not. And I wonder whether it will ever happen that way. There will be changes, and not all of these changes probably are bad, let's face it.
Sharmistha?
I share cautious optimism as well, in particular, given the extremely high efficacy of the vaccines to reduce hospitalizations and death, prioritizing to those in whom we're seeing hospitalizations and death through infection, and then through the added element of age and comorbidities, is going to have a dramatic impact, as it's starting to already have in other settings where coverage has gone very high. And that gives me a lot of optimism. The seasonal effects that come from, being indoors, being outdoors, and knowing how the virus acts very differently indoors and outdoors. Again, there's nothing to suggest data-wise right now that the summer should be very different from our last summer. And what's important, therefore, I think, as Peter said, is it's the next fall, winter will be our test. It will be our test of the extent to which from now until then, we have been able to address in the short term, which we can do, those things that prevent effective isolation and quarantine support, getting our workplaces safer. So where we're seeing the outbreaks now, if we can get those workplaces safer across many elements, including schools, but especially factories, warehouses, or farms, then that'll be our test in the fall and winter, and also our congregate settings. So all of the measures, all the recommendations that have been, put forward to ensure that those are places where there's going to be less transmission than there was in 2020. That's going to be our test. And so the hope is that an element of vaccine coverage and sort of that element, understanding more about what's going to happen with the virus over time in terms of its mutations and so forth, and then adapting to that. But also, I think my hope, and perhaps I'm being quite an optimist here, is that the new normal will be the structural changes that get us to a place where we see way less potential for these larger outbreaks across our, in particular, workplaces and congregate settings. So it's really that element, which I hope is going to be the new normal.
Mm-hmm. That's really good, Sharmistha. I mean, firstly, I'm also an optimist. In fact, I claim I'm an incurable optimist. And also what you say exactly right, that in the midst of all of this that we're dealing with, that the end result might be, if we'll be optimistic, a social improvement, actually, in terms of some of these structural issues that you've mentioned. That's very good. Let's talk a little bit about the variants of concern, the new versions of the virus that are making themselves felt, albeit slowly in Ontario at the moment, but they may pick up. So this is a question from Leah Cousins, and she asks, with the new strain now in Ontario, how much longer will it take for us to overcome the virus? If we are still not seeing our numbers drop with the initial strain of COVID, can we see our province becoming normal again in the next 2 years with the new strain? So apart from the details, it is a question of the variant of concern being present in large numbers and how that will affect or delay our ability to deal with the pandemic.
Yeah, so again, Sharmistha is indicating I go first, you come second there.
I like that.
So look, I've been in the media relatively prominently with saying, that these new variants are the single most scary thing as an epidemiologist that I've seen since the beginning of the pandemic, and that's actually true. So we need to be aware of the problem we have now is we right now are relatively successful with bringing our numbers down, but this is relatively deceptive. The problem is this thing, the new variant. Right now we're talking predominantly just about the UK variant, but there are others that could, arrive here too or have arrived, but don't have community spread yet. They grow in the hidden, basically concealed. And this is very much a bit like, for those of us who like Tour de France, I don't know, this is like, the biker in the field that just basically grows stronger and stronger, and all of a sudden overtakes everybody and is in the front. And what we have, I quickly can show you just a graph just to understand that. Basically, some of you will have seen this graph. This is coming from oh my God, what's from Troy Day. Some early looks at how this potentially could look, and what you see here in red is this variant, you know, that actually at the beginning lingers around down here and grows, and it looks at if it grows very slowly. But remember how the situation is: 1 becomes 2, 2 become 4, 4 become 8, 8 becomes 16, etc. And so it goes. And if this now doubles every week, at the beginning it's still down here, the numbers of cases, but all of a sudden this thing explodes. No, that's what you see here, and that's what the relatively early models showed. Now, where we are right now, and let's assume we become overly optimistic right now. Okay, this was just some parameterizations of models I did just yesterday. Actually, let's assume we say, okay, it goes so well. We just reopen on February 10th. That's in a few days from now, so that the restrictions are more or less the same way as in early December. You remember early December how it was? We could do a little bit of something, etc. There was still growth. What would this mean? And what you now see here is down here at the bottom, this is the variant, and this is not made up. This is actually, you know, data that we also have, basically based on the doubling time that we now are aware of. This is the variant being down here, and nobody will notice it, you know, and we are successful. We bring the numbers down. We continue to bring the numbers down. But all of a sudden, you know, when 20% of the cases were done or were caused by the new variant, the UK variant, a week after the 20%, it will already be 40% of the cases. And the week afterwards, it will slowly approach, or not slowly, very rapidly approach 80% of the cases being the new variant. And what we then see, basically somewhere between end of February and perhaps mid-March, we can't tell where it is. It will be basically the biker taking over, being in front and dominating the pandemic. And if we were just to go back, there were a lot of restrictions in early December. If we were to go back to that and stayed naive, what will happen, and this would, you know, this is not theoretical, that's unfortunately very real, what we're seeing here. This new variant takes over anyway, then in a moment, we will get this pandemic completely out of control. It won't work anymore. Sorry, I'm lost with the slide here. And that's the real challenge we're talking about. Look at Portugal, look at the UK, that's what happened there. And that's what we need to avoid. And even if we stay right now in the lockdown that we are right now, once the variant takes over, the negative growth, you know, the downward slope will stop and it will go slowly upwards again, you know. So that's why it's important that we do the right thing now and that we are very careful and don't get overly naive. We now are opening schools. We can't open much more because we don't want to end up in this situation, and we want to make it into spring now. Spring will help and the vaccines will help, but we need to be very smart and shouldn't be naive. This is a reality here. This is not just a theoretical concern. This is guaranteed that this is coming, and we don't want it to look like that. I'd rather prefer to have it look like this, and probably all of us do.
It's interesting, Peter, that you know, when we say we want it to look like this, I remember the first time we saw models saying that we're going to have daily caseloads of 1,000, we were scared, and now we're saying that if we can keep it at 1,000, we're okay.
Indeed. Yeah. And you know, the point is, that's where Google and Apple help us that tremendously. You know, if you look at that, we actually can monitor relatively well what all of us do. No, that was, when you look at that, the solid curves basically show you that's the stuff that you would not really like well, that you would really like to do, but what you shouldn't do, go shopping, drive around, do whatever, and the dashed ones would be, be staying at home, walk in the park or walk outside. That's what actually would be okay. And the point is that, and that's work here. The black one is work, and we're still 10% lower than in December. All of these decreases in mobility help us to keep the pandemic now in check. And we're actually doing a much better job than all the other provinces right now in Canada, which is great. And therefore, we're still quite okay. But now remember, once we are beginning to mid-March, somewhere there, when the new variant takes over, even these restrictions as we are right now will not be enough. We will not have negative growth anymore, but we will have a situation like that. At least it's not too difficult. And the point then is then slowly we go outside, things will get easier, and hopefully, yes, Pfizer and Moderna and others will have provided us with enough vaccines that we can vaccinate smart.
Sharmistha, do you want to add something?
I think just 2 points to exactly what Peter described is that in many ways, even if you look at a homogeneous system, so forgetting about heterogeneity by risk context, in some ways what the virus or the variant, B117 in particular has shown us is that it's acting like that heterogeneity piece. It's sort of, it's just over time, but it's elevating that risk. And so where would we see the effect of that amplified risk of increased transmission is where we're already seeing our dense networks. So, I don't have these figures up here yet, but where we see that even bigger differential in terms of where things could get worse are going to be in our workplaces. And as we've already observed in congregate facilities, for example. So it's that amplifying effect that is important, but it's compounded even further with dense networks beyond sort of just a multiplicative effect. That's one. And the second is, I think this speaks to the importance, as Peter was describing, of strategic prioritization of vaccine coverage, where the impact of increased transmission is going to lead to hospitalization and death. So really prioritizing where we know we're going to see more hospitalizations and death, and preventing that as fast as possible through vaccination mechanisms.
So it's just really important right now to realize we're really quite far in this marathon, but we're not at the final line yet. And now it's really important not to make a fatal mistake, because it could backfire big time. And there's a silver lining. It's coming. We have two, the weather, seasonality, plus the vaccine. But right now, let's not make a big mistake.
And to that effect, this element of the game hasn't changed, but it's added on additional elements that actually could potentially widen the prevention gap if we're not strategic about our intervention strategies.
Okay, so this is a good segue into our next topic about vaccines. And I was happy to get a question from probably the furthest from Toronto. This is from Chief Paul Burke of the Fort Severn First Nation. For those who don't know, Fort Severn is at the tip, I guess named James Bay or something. It's near the northern part of Ontario. And what he asks is, he is hearing a lot of discussion in his community about the vaccine and would like to understand why a second dose is needed in a vaccine. What's the philosophy behind that? And maybe in addressing this, maybe we could also speak a little bit to the whole the different vaccines and the way they work.
we develop a habit here.
Yes, we have.
So
your protocol.
Okay. So first of all, it will depend on the vaccines. You're aware of that. There are different technologies out there. We have the new game changer, which will be very elegant in the future too. That's the messenger RNA vaccine. And for those, it has become established based on the studies we do in smaller sets of people. Where we see that when we give one dose of the vaccine, that the antibodies that we need to defend the virus, there's a certain type of antibodies which is called neutralizing antibodies. That's antibodies actually that are able to catch the virus in a way that it's not biologically active anymore. That's the beauty of it. So that's the one that you actually strive for when you're a vaccine developer, ideally. And what we know is that after the first dose, these neutralizing antibodies go up to a certain level. But when you compare it with people who have undergone infection, you're basically, just more at the lower end. And once you give the booster dose, we do that also for other vaccinations. Basically, these neutralizing antibodies really go up heavily. And it just, based on the lab data, we just know already, okay, it could be a jolly good thing to have the second dose, but be aware, there are other vaccine technologies, they do have protocols with just one dose. It depends on the technology. Now, this would all not matter if we wouldn't see that there are some changes there as well, in clinical reality. So the large-scale trials that look at people who either got COVID, the disease, not just the infection, but really just had developed symptoms or even severe COVID. When we look at these trials that assessed that, whether people got COVID or not, what we typically find is that after the first dose, there's already good efficacy. It's actually still higher, for instance, than what you see with an influenza vaccine, with a flu vaccine typically. But after the second dose, this thing really starts to be at a really high level. The efficacy is then roughly 95%. What does 95% mean? It means out of 100 COVID-19 cases, 95 get prevented. And if you just look at the efficacy after the first dose, you're perhaps only at 85 out of 100 cases that get prevented. And we don't know whether this fizzles out over time. So the second dose also means that you're probably protected much longer. Therefore, we're keen on getting the second dose aboard, but we're not that fast. At least I am not that fast, whether this is after 3 weeks, 4 weeks, 5 weeks, or 6 weeks or so. We want to get it aboard sooner or later, and feel it's more important for, those people are really vulnerable, like the long-term care home residents, to get it perhaps within 4 weeks, that they just have optimal protection. But it's not such a big deal if you're a bit later. In fact, we know from other vaccines, the later you get the second dose, the more efficient is the boost.
Mm-hmm. Interesting. Sharmistha?
No, I think that covers it really well. And thinking about that timing element, that's all just, efficacy or how well something will work to protect against getting, severe disease in particular, or symptomatic infection in particular, and definitely hospitalization and death, which we're trying to prevent. But that's all if exposed and infected. So while all of this is taking place, sort of high coverage of that first dose, as we're working towards getting to that second, all the other things that reduce the chance of getting infected, that 85% in that first period might actually lead to less deaths than that getting to that 95% later on, because over those 4 weeks, 5 weeks, hopefully we've also reduced the chance that someone can become infected. Mm-hmm. So it's those two pieces together.
Mm-hmm. Okay. So
therefore, we advise the province, not unlike other places in the world, to reserve at the beginning, when we have a shortage of doses, not to reserve for second doses, but just to get as many needles in as many arms of vulnerable people as possible to get there. And we also, we also develop mathematical models to show under different scenarios what would happen, and it's probably the best bet. One more thing that it just occurred to me, something that I would just like to raise quickly, because I see that again and again as a misconception because of this messenger RNA thing. So there's absolutely no way, biologically speaking, that messenger RNA would find its way into your DNA, into your genetic material. First of all, messenger RNA is completely unstable. That's why we need to freeze these vaccines to -80 or -20. Second of all, in the body, in all mammals and everywhere, there's a one-way street that cannot go backwards, which is the one-way street goes from DNA to RNA, basically, and not the opposite. You know, this is impossible. So basically, what we know with these new vaccines coming from Pfizer and Moderna, they're really the best bet regarding efficacy and safety that we probably have had in a very long time with vaccines. And imagine now how many million people have been vaccinated. It's really safe, this thing. And there's no way, I sound like a broken record, but it's really important for some people out there just to hear that. There's no way that mRNA could make its way back into DNA. Impossible, period. 100% impossible.
Okay, so those are very clear answers. Thank you for that on the vaccines. Now, being mindful of the time, we have just a little over 10 minutes, and I want to get to two questions. One is from a young undergraduate in Toronto. His name is Elias Wolanaki, and he asks the following. I'm assuming, I'm not quite sure whether it's a he or she, but the question is this. It's a computer science and mathematics undergraduate student. And the question is there anything we could do to help COVID-19 analysis? Are there specific opportunities, or more generally, what might your recommendations be for such individuals who wanted to help in some way? I wanted to ask you this question, raise this question, because it's clear in all of our discussions and all of the tables and the committees, you know, it's taking everybody's brain really to be part of this effort to try to figure these things out. And so I can see the youngsters, the future scientists, also wanting to use their knowledge and their ability in this very critical time. So I was happy to get this question. And what kind of advice would you offer our young friend?
So I think reach out to folks that you have that you've seen on either talks or through the websites with the various panels and the committees, the research institutions. For undergraduate students, I'm thinking about the field summer student program, for example. There is an immeasurable wealth of methodological work that is still needed and undergoing, a ton of applied work, and certainly the more, especially interdisciplinary science that this can foster, the better. And networks are getting together to build capacity in this. So I'm hoping that through various task forces and networks and research collaborations, that there'll be opportunities for more trainees and students. So really another, I guess, again, cautious optimism on my part is over the next few years that we've built capacity in a collaborative kind approach to these difficult questions that are raised of us with different and difficult timelines sometimes as well. So I would say reach out, and if folks don't answer, reach out again. It works. It worked for me as a trainee to reach out several times.
Yeah, so true. And by the way, if there's a really great R programmer or a box programmer out there who would like to volunteer, you know, be welcome and just reach out to me directly. I'm thinking about, you know, certain tools that I would like to develop during the next few weeks or so anyway. So just reach out directly. Okay,
very good. That's very encouraging. And Mr. Thanks for pointing out, yes, the Fields Undergraduate Summer Research Program is an opportunity. There are many seminars, many industrial problem-solving workshops coming up, thematic programs coming up, in fact, this summer on integrative modeling. And I'm sure it'll be interesting to have undergraduates be part of that as well. So that's a positive answer to our young friend here. Last question I want to ask you in the few minutes that this question is from me. So far I've been asking you questions from others. So now I'm going to ask you a question from me. You see, I know both of you are very accomplished professionals with a very busy research and teaching career. Pandemic has skewed everything, you know, in terms of the amount of time that's being devoted to studying it as opposed to your other research interests. And beyond the professional impact, there's also the personal impact. You have families, you're affected just as everybody else. Can you speak a little bit to these two sides of the impact and your reflections on 1 year into this very unusual situation?
Me first. Okay, we stick to that. Apart from the last question, actually, I mean, look, it's little did I know. No, I remember when I was beginning of February, I was with my hairdresser, and she was actually at beginning of February much more concerned about this pandemic, being originally from Toronto and having experienced SARS than I was at that time. And I remember I was once more with the hairdresser much later. The first thing I did, I apologized with her because at that time I told her, yeah, we'll see, it may not be that bad. And the first thing I did, I apologized. When I saw her probably in August or I don't know when it was. Since 1st of March, I haven't had one day off, and I haven't had a day when I didn't feel like being back in med school. This is a bit confounded because, you know, as you have when you read, you know, my short bio sketch, I was not an infectious diseases epidemiologist. So I basically started beginning of March and became over these months probably quite okay. I know quite a lot now about the disease, but you know, if it comes to mathematical modeling, etc., I'm still learning. Okay, and I'm basically it completely put everything upside down in my career, and it completely changed my focus, and it also completely changed even my attitude or my connection to this province. You know, it has become something extremely personal. Also with this job that I then, you know, was asked to take over beginning of July or so, where I was really scared when they asked me, and I felt, okay, this little Swiss boy, shall I really do that? Am I really up for it? Actually, it really scared me at the time. And it actually scares me still sometimes. It basically changed my attitude. It has become very personal for me, but also in a really good way that I just feel, okay, I've been trained, life has trained me for 25 years, and I feel it really as a strong privilege now to be able to try to help a little bit and hopefully not mess it up too much. For my family, it's crazy sometimes, you know. So Elena, my wife, she basically has my back all the time, is looking after the children most of the time, and sometimes probably could murder me. But when this was about, you know, whether I take over this job or not, we discussed it, and we both said, okay, it might be tough sometimes, and it is. But there's also, you know, this really big privilege just to be able to help a little bit. And there's this other part, what I really find extraordinary in this province. You know, I've been here only for a bit more than 5 years. But the amount of great people like Sharmistha, you know, who I only got to know during the pandemic, actually, you know, and the way we work together across disciplines, etc. This is really, really remarkable, and it keeps touching me really daily, you know, in the ministry, at PHO, across the universities, at the hospitals, also the international collaborations. It was life-changing for me, and in the best possible way, even though it's tough and even though it's a boot camp.
Thank you, Peter. Sharmistha.
Yeah, I echo the boot camp analogy. I feel privileged as well. I think I feel privileged, and I've been extremely humbled, but also I can't say how amazing it has been to be challenged and to challenge each other and to question what I've thought for a long time, or how I've been trained in something, learning a new aspect of an element. So Peter, I think the discussions that we've had where we try to think things through, the discussions we have within our modeling consensus table, where we're really trying to explain and go over our work and figure out whether our logic and our reasoning makes sense, interrogate the data. That has been phenomenal, and doing it across disciplines rather than, well, I'm the modeler, so I know that, and, taking that aspect, that's been phenomenal. What I found challenging professionally has been at times, and partly due to the stress of a pandemic, sometimes the discourse more in the public realms versus I think in our working groups and in the meetings has sometimes become a bit divisive and personal and in the public eye. And so I think it would be nice to see a shift in that over the next couple of months as we come back to being open to discourse and questioning each other, and the data, and looking at it from different perspectives versus sort of personal attacks and arguments that I've seen in the public, which has been challenging professionally. Personally, I would say, again, I feel like I think the equity element and seeing South Asian communities disproportionately affected, both in the data that I work with, both from a personal perspective and then as a clinician in the hospitals, has been challenging. And so, but then that reflects again sort of that, role to serve. And so I feel very privileged for that element of it.
Nice, beautiful answers, both of you. I also feel the same way, that all the people that we've come into contact through the modeling table and science table, it really is remarkable to see both the intellectual power, but also the human side, the dedication, the many long hours that people put in to work on these problems. So thank you for everything both of you do. And thank you for taking the time to chat with us today and shed light on some of these questions which are coming from the public. Now, I understand there's a lot of chat on the YouTube channel, which we couldn't get to. So my friends who are listening and contributing your ideas on the chat, I just want to say to you, thank you, firstly, for your interest. And we hope that if this interest is maintained, then we will try to organize further programs where we communicate. I think this kind of communication is very important and very helpful on both sides. So we have your comments and your questions, and we will try to address them in the near future. So in bringing the event to a close, once again, thanks to Peter and Sharmistha for your wonderful commentary on the issues. Thanks to all of you who logged into this. And also thanks to the staff of the Fields Institute. I keep telling you that if a program goes off smoothly and easily, it's because somebody's at the background working very hard to make sure it does. So Brian, Kirsten, Jordana, Sarah, Miriam, and anyone else whose names I left out, thank you so much for making the program run smoothly. Please do stay connected to the Fields Institute. We are here to serve. Our root is mathematical sciences, but we live in a world where there's not any part of society in which mathematical sciences doesn't have an impact. And so please do stay tuned, stay connected, talk to us, join our programs. And most importantly, right now in the current environment, please stay safe, stay healthy wherever you are, and we will see you again. Thank you and good night. Bye.